Choosing the right bariatric operation for you can be a little confusing, particularly if you're trying to do it on your own. There are two main types of bariatric surgery that are performed. A restrictive procedure, such as the sleeve gastrectomy or the gastric banding operation, works predominantly through a reduction in appetite and the size of the meals that you can eat in any one time. Whereas a malabsorptive procedure can allow calories to sneak out the bottom end, but perhaps more importantly, by diverting food into lower parts of the intestine, we see the production of very powerful anti-appetite hormones that are effective against strong hunger and also effective against type 2 diabetes.
These are the 4 operations that are offered in my practice. The sleeve gastrectomy is the most commonly performed operation. It accounts for about 80% of surgery in Australia actually for weight loss. The mini gastric bypass accounts for most of the rest. The bottom 3 operations are all versions of bypass operations, whereas the sleeve gastrectomy is a restrictive procedure. We'll discuss each of these in turn briefly. There's more information on each of them in specific videos available on my website. In the sleeve gastrectomy, fat is removed from the outer part of the stomach initially, and then staplers are used to divide the stomach with one part that we're going to permanently remove. A tube is placed by the anaesthetist down through the mouth into the stomach tube that will remain during the procedure to help to guide how wide we leave that tube. Once we've finished, we remove the stomach piece and we sew the fat back onto the staple line. So this is a relatively straightforward procedure for bariatric surgeons to perform and has the lowest risk of any of the operations that I do. It leads to pretty good weight loss. It leads to weight loss predominantly through a long-term reduction in hunger and appetite, because when we have a tube-like stomach, there's a build-up of pressure. This happens because there's a muscle at the bottom part of the stomach called the pylorus that's normally shut. As that pressure builds up in the tube-like stomach, it's detected by some nerve endings that send signals to the brain to turn off the appetite. Ghrelin is a hormone produced in the stomach, and it's a hunger hormone, so there's less ghrelin around after the surgery for your body to use to make you feel hungry as well. And the other way it helps with weight loss is obvious that when meals are taken, only a small meal can fit into the new, smaller stomach. So when people eat, their food comes down their gullet into the long, thin tube of stomach where it gets held up for a while. A small meal will satisfy people. After that, it leaves the stomach and mixes with the digestive juices at the level of the green arrow, and then digestion happens normally. This means less of the potential loose stool problems that we can see with some of the bypass operations. A leak is a rare but can be difficult complication to deal with. It means that somewhere along the staple line in the first weeks after surgery, there might be a breakdown of healing. This can lead to an infection just outside the stomach staple line that would need people to be hospitalized and have treatments for. Thankfully, although it was a not terribly uncommon problem in the early days of us performing sleeve gastrectomies, we've learned how to avoid it by and large, and so this is something that is very rarely seen these days. About 1/3 of people will get some reflux because acid that's made in the lower part of the stomach in this operation does tend to get pushed upwards, and there's a weak one-way valve at the level of the red arrow called the lower esophageal sphincter, and if the acid gets past that, then it can burn the esophagus with heartburn. The traditional or Roux-en-Y gastric bypass is an operation that's been around in some form for decades. In this operation, no stomach is removed, but the staplers divide the stomach into 2 parts. One part's called the pouch, then the bowel gets divided and one part comes up and joins on to that pouch of stomach, where the other part gets joined onto itself. So when food is taken, food initially goes into its own bit of bowel without any digestive juices, whereas the digestive juices travel in their own bit of bowel, not mixing with the food until the level of the second or lower join, and after that mixing and digestion happens at the level of the yellow arrow. It turns out that if food is digested in the lower part of the small intestines, then hormones that are very powerful appetite suppressive hormones are produced. These also have the happy coincidence of correcting some of the factors associated with type 2 diabetes. And that leads to a strong anti-diabetic effect for type 2 diabetics. And because the majority of the acid is not made in that little pouch, reflux can be resolved with this operation. However, it's quite complex surgery. It has a relatively high complication rate compared to the other operations that I offer. And so generally I reserve this for patients who are having revisional surgery, meaning second time or third time surgery after previous stomach surgery. The mini gastric bypass is a poor name. The word mini really refers to a less complicated operation than that traditional bypass we just looked at. Not that it leads to less weight loss. In fact, most of the time it leads to more weight loss than the traditional bypass. But it's certainly simpler to perform and has less complications associated with it. And again, it's a hormonal driven operation. So in this operation, we have a long, thin pouch of stomach instead of a short, fat one like we see in the traditional bypass. We measure out the bowel that we want to bypass. Then we make a join between the long, thin pouch of stomach and the side of the bowel. This means that food comes down the gullet, enters into the long, thin pouch of stomach before entering into the bowel, whereas the digestive juices travel in the first part of the bowel without any food to work on, and true digestion only happens after the second join. This is a low pressure tube, which means that there's less reflux and heartburn than we see with the gastric sleeve. We can get a complication called bile reflux, which can be problematic and occasionally requires further surgery to correct. It's a good operation for people with diabetes because, again, those hormones are anti-diabetic. But people can get stomach ulcers at the join, and everybody needs to take anti-acid tablets for months after the surgery to try and prevent this from happening. Smokers get terrible ulcers, and so I won't offer this surgery to people who are current tobacco smokers. People can get loose stools or have problems with absorption of some of the vitamins and minerals and even protein, and therefore it is an operation which requires diligent follow-up and adherence to nourishment advice, including daily multivitamins and regular blood tests, particularly in the first few years, to make sure that there are no deficiencies building up. The SASI procedure is a newer procedure for me. In this operation, the sleeve is created much like we do for a sleeve gastrectomy, and we remove most of the stomach. Then we measure the bowel and we make a join between the stomach just below where we've stapled the sleeve and the side of the bowel. This is a side-to-side join rather than an end-to-side join like we saw with the mini gastric bypass. What this means is that food, once it passes out of the sleeve, has a choice between going down through the join into the lower part of the small intestine or traveling in the normal route. In practice, about 70% will go into the bypass and about 30% will go in the normal route on the average person. What this means is that we get the food that's going into the bypass triggering all of those hormones, and again leading to powerful appetite suppression and correction of diabetes. But because food also goes in the normal pathway, mixing early with the digestive juices and giving the jejunum, or the upper small bowel, a chance to work on it, we see far less nutritional deficiency problems, and it to a large degree minimizes the chance of having problems that we sometimes see with the other bypasses, like dumping syndrome and malnourishment issues. So this is a hormonal operation predominantly. There, of course, is little restriction and decrease in meal size. We still can theoretically see bile reflux, but probably less commonly than we see in the mini gastric bypass. Because it's a bypass, we still need to be vigilant with nourishment advice and monitoring of blood tests, etc. I think if there's a negative about this procedure, it's that it's relatively new. Although it's very popular in certain pockets around the world, it hasn't taken over the job of the sleeve gastrectomy or the mini gastric bypass at this stage in this country. So there are some important questions that we can ask about individuals before we recommend a particular procedure. We can ask if somebody's got type 2 diabetes. If the answer is yes, then one of the bypass procedures should be considered because of the added endocrine benefit from that. If they are a smoker, then a sleeve gastrectomy would really be the only option because of the risk of bad stomach ulcers related to some of the bypass surgeries. If people are young, then my tendency is to recommend a sleeve gastrectomy because over decades of life, if there was a trace element that was not being accounted for, that was missing after a bypass, that person could end up with problems in their old age. So the younger the person is, the more likely it is that I would recommend a sleeve. If there's any bowel problems, then again I would recommend a sleeve for patients with bowel problems because the bypasses all require surgery onto the bowel. If people have got are very heavy and have a BMI above 55 or so, then one of the bypasses is probably going to be a better option for them because it will help them to lose that extra amount of weight and get a stronger chance of getting them into a healthy weight range. And lastly, if it was a revisional procedure where the reason for revision was reflux and heartburn alone, then typically the traditional Roux-en-Y gastric bypass might be the best procedure under those circumstances. I hope you found all of this useful in understanding these complex procedures. Of course, the advice that I've given here is very generalized, and I do advise you to make an appointment to see me if you've got further questions.
Well, I hope you found that helpful. You can access lots of information on my website, but we'd love to hear from you. You can get in touch on my email or during business hours on the phone number.